I will just try to focus everything on the tibial plateau fracture. Primarily, why to focus on the posterior medial corner is to describe the modalities of the treatment, classification, importance of the anatomical reduction, and early mobilization. Already the things are known. Early the mobilization, better is the result. Within 3 weeks period, one can expect around 90 degrees of the flexion. And once you are going to achieve the 90 degree of flexion, most of the job is performed very comfortably. Beyond this, whatever you are going to achieve is the really good for the patient and even make the surgeon very, very happy. In 90 degree of the flexion, one can sit comfortably on the chair. One can travel comfortably in any train or bus without hitting the limb of the other people. So 90 degree flexion is good enough to perform majority of the function in around the knee joint. But once you are going to get the complete range of the movement, the person will be able to squat or sit cross-legged. The tibial fracture has got a varus or valgus forces combined with the axial loading. Tibial condyle is split by opposite femoral condyle. The mechanism is well known and clinical features and examination is mandatory. Although this fracture is looking very, very simple, not too much of the comminution, but patient is having a blister formation on the medial side of the knee, below the knee joint. So this suggests a lot of soft tissue injury apart from the large hematoma formation in the knee joint and around the fracture site. So one has to wait till you are going to get a, this you are going to get a disappearance of the swelling and you will be able to handle the soft tissue in a better way. X-ray is important, but CT definitely is a gold standard to manage any periarticular or intraarticular fractures. This is going to give you a lot of information about it. Here it seems simple, like the medial condyle is looking very, very simple here on this side. But once you are going to have the 3D reconstruction, you can see a medial condyle has tilted with a tip is facing more on the lateral side, and there is also a posterior part of the condyle is broken on the lateral side. So what you do need, you do need to reconstruct this medial column, and reconstruction is very well possible once you are going to put the screw and plate from the medial side to start on the medial side. Because starting from the medial side, you are going to handle a large piece of the medial fragment, which is very well possible, and over it, you are going to reconstruct the rest of the fragment in due course of the time. The typical is if once you are going to work with the surgical classification, this may be a type 1 pure cleavage, common in younger patient without osteoporosis. Management is simple, but nowadays, not barely putting the screw across the fracture site, you do require an anti-glide plate to make sure there will not be a displacement in due course of time, and early mobility is very well possible. There may be a depressed fracture, but they do require a articular reconstruction and putting the plate and the screw on this side. One thing you can notice it, we did this surgery without getting a CT scan done. So what we missed? We missed we have seen the fracture on the lateral side here only, but we missed the fracture on the medial condyle on this plane. So after the reconstruction from the lateral side, there was a medial collapse and a varus deformity in due course of time. So most important is to get a 3D CT scan reconstructed picture, and same time the support of the medial column is very, very important. Once you are going to support the medial column, the varus collapse will be significantly prevented. So this is one of the very, very important point to take care of the medial collapse. In cases of bicondylar fracture, or one has to go for a fragment or condyle has to be fixed according to the need, and plate or the screw must be placed according to the need of the patient. Type 3 may be a pure central type of depression, and one can go for a reconstructive surgery by putting a plate in the screw. The most important talk is here to focus the primarily the how you are going to reconstruct the medial column of the proximal part of the tibia. One can realize about the depressed fracture on the medial side here, and same time the fragment is also there is a displacement in the anteromedial part of the tibia is also significantly displaced. So at the time of the surgery, what you do need? You do need to elevate this part of the fragment proximally, and same time the fracture fragment from the anterior part has also to be taken care of. So we did a open reduction for the medial side, and a plate was placed primarily on the medial side, but you can shift this plate to some extent on the anterior side or to some extent on the posterior side. This plate was shifted more on the posterior side, although this plate is primarily designed for the medial column fixation. So after putting the plate along with the uh, this subchondral plate screws, the stability was good, and the patient achieved a good functional outcome at the end of the day. Another patient where there is a fracture is primarily on the medial side. We did a open reduction internal fixation by putting a plate screw on the posterior medial side. This plate was placed on the posterior medial corner, fixed by a locking screw, which was passing from the posterior medial corner to the anterolateral side, and the another screw was placed from the anterior to the posterior side just to hold this small fragment which was jumping out at the time of the surgery. So one can achieve, although there was a avulsion of this tibial tuberosity was there, which was getting attachment of the ACL. We did we have not operated or fixed this fragment on the table apart from putting a few sutures around it, and this has behaved very well in the post-operative period. Type 5 is a bicondylar fracture. Whatever problem is there, either with the Sajka grade 5 or grade 6, you do require to reconstruct the medial column first by putting a medial plate, posterior medial plate, or sometime medial plate on this side and another plate on the lateral side. We did it by putting a bicondylar fixation. At the end of the day, the patient was having a full normal range of the of the movement. Sometime I do like to put most of the time I do like to put these two plates by two separate incisions. But once I am going to place the plate either on the medial side or on the lateral side, not a posterior medial side, I will like to go for a midline incision, reflect the soft tissue on the both on the medial and lateral side, place a plate on the medial side and also on the lateral side. But occasionally this incision is going to have the problem because of the necrosis of the soft tissue at the margin. Even a small loss of the soft tissue may lead to a lot of problem in due course of time. One should be very, very careful at the time of the soft tissue dissection, and there is no problem. One should not feel any problem for putting a dual incision rather than putting a single incision and stretching the soft tissue too much on the both sides by putting midline incision. Type 6 is a both tibial condyles and articular surface are fractured, and one can do the job. Whatever you are going to do the job, you have to fix the posterior side and then place the plate on the lateral side. He was having the good range of movement at the end of the 8 weeks period, although one can expect around full range of the movement at the end of the 12 to 16 weeks period if the reconstruction of the joint is comfortable or well within anatomical limit, the function is expected nicely. Another example of the patient where we did a fixation on the medial side, then followed the fixation on the lateral side. Although this is going this fragment is going in hyperextension, but joint surface is very well restored with a small bit of the collapse on the medial side, and there was a small bit of the varus on the medial side. But patient was okay clinically, and the range of the function was well acceptable. These are the quite old slides. Some of the slides are quite old, but definitely in due course of time, any surgeon is going to grow the experience on their themselves, especially the intraarticular surface. One cannot learn everything just by looking upon the slides, looking upon the surgery. But once you are going to perform the surgery by yourself, then you are going to realize the importance of the restoration of the fragments anatomically and fixation by putting either a dual plate or by putting in more than two plates even. So one has to decide how you are going to fix it. Sometimes there is a gap is there, One can put the either cancerous bone graft, or occasionally the artificial graft is also equally or also required to make sure you are going to fill up the cavity and going to support the subchondral bone. An example, there was a big void was here, but this because the patient was having a good cortical contact both on the medial and lateral side, we left it as such. And in due course of time, because of the good hematoma formation, this has healed completely. The complication may be there: early compartment syndrome, neurovascular injuries, fracture blisters. If you are not going to mobilize them, there may be stiffness, deformity, osteoarthritis. Putting a hybrid fixator is one of the proper choice. Recently, in Corona period, in last 3 days period, 3 or 4 days period, we have operated two patients with a lot of blister formation around the extremity. We waited for about 2 weeks period with a wrinkle sign positive, but patient was still was skin was not looking good. So we have applied the traction distractor. The fragment was held by putting a point holding forceps and applied the ring in both of the articles. Surface was fairly well restored without having any soft tissue complication. Respect the soft tissue. Column fixation prevent the malalignment. Early mobility is mandatory. Pre-contoured and non-bulky implants are superior than the bulky implants. Thank you very much.